let me first introduce myself. My name is Marc Connell. I'm an orthopedic surgeon, and I've been in practice here in the Washington, D.C. area for, this is my 29th year now. I've been with Washington Orthopedics and Sports Medicine my entire career. I trained here as well, at least in part, did my residency in orthopedic surgery after medical school at Georgetown University. Finished my training at Yale University, where I did a fellowship, and then returned here in 1993 to start practice, and have been here since. So my subspecialty interests include both arthroplasty, that is joint replacement surgery, as well as arthroscopic procedures of the major joints, particularly the shoulder and the knee. But tonight we're going to limit our comments to arthroplasty. Because of my interest in both arthroplasty as well as sports medicine, I've sort of developed a different approach to consideration for both arthroscopic and arthroplasty options, and sort of bridging that nexus between sports medicine and arthroplasty. I have developed particular interest, expertise, and experience with knee in particular, which is really the meeting point, the nexus of those two subspecialties. There's probably not any greater, certainly there may be equal, but no greater area of evolutionary development in orthopedics over the course of my professional career than in knee arthroplasty. And while it's been an exciting 3 decades to be in the field, the evolution continues, and in fact, I think has perhaps increased in speed over the last decade, particularly with the advancement of technology and the merging of both computer navigation and robotics in knee arthroplasty. So initially, it's always best, I think, if you want to understand where we are and where we're going, I think it's prudent and important to review briefly the history of arthroplasty as it relates to, for decades, really until perhaps 10 years ago, the standard of care for total knee arthroplasty was to use a combination of both intramedullary and or extramedullary jigging systems. The canals of the femur, that is the thigh bone, and the tibia, that is the shin bone, were used as a frame of reference off of which the mechanical axis of the knee would be measured. So if we could drop a plumb line, if you will, down the intramedullary canal of the femur or the tibia, we could trace a perpendicular to that and then make our cuts accordingly. That's a simplification of it, of course, but basically I think the concept holds true, particularly in the tibia, extramedullary landmarks, that is using bony landmarks outside of the skin, not to mention the medullary canal, are also greatly popular and reproducible, and I think have a very strong place even to date in our armamentarium. So the systems that have been used and that are presently used for the majority of arthroplasties are modular. In fact, they're highly modular. There's 4 different components that go into the knee arthroplasty, and some of them are as close together as 2 millimeters in size, different one size to the next. With great modularity comes great flexibility. Additionally, there are reasons why intraoperatively one might choose to take a different tack, a different scenario, and require a slightly different approach in terms of the types of implants that we use. Some of them, for example, may be stemmed and extend up the femur down the tibia, as opposed to the standards, which are cemented onto the surface, if you will. Think of them as resurfacing arthroplasties. much in the same way one resurfaces a road, for example, with a smoother, more congruent and perpendicular surface. So that's the history from really the nascent, earliest systems for total knee arthroplasty back into the 1970s, a very rapid evolutionary process in arthroplasties in the 80s and 90s. If one were to look at the various systems from the 70s and 80s, they were wildly different. And in fact, you could pick out, what the brand was simply by looking at a post-operative X-rays. They look so different. As the technology has matured, similar to cell phones or computers or automobiles, the devices become much more alike than they are different. They all have their specific peculiarities that make them interesting or attractive for one reason or another, but generally they're variations on the same theme. So that is sort of the background on total knee arthroplasty. Starting around the turn of the millennium, around 2000, we started to see the concept of more customized devices. The first of which were custom jigs that are shaped appropriately based on CT and MRI findings of the patient's hip, ankle, and knee. And they were used as patient-specific jigging systems to make it a much more customized approach. This was a great advance, and I think probably its greatest value was in allowing us to really take a minimalist approach to bone resection. Bone is gold, and the earlier in life you need a knee arthroplasty, or any arthroplasty for that matter, the more important, the more critical it becomes to try and preserve bone, both for present circumstances as well as for future use. It is typical that we expect in modern orthopedics for an arthroplasty to last, 20 to 25 years is reasonable. We've got many people who are well past that, into their third decade, into their 30th year, I should say. So that's not an unusual outcome, but the earlier you get your arthroplasty, is the younger you are, more and for a longer period of time. If someone gets a knee replacement at age 80, their expectations and activity level are different from your average 55-year-olds, as you can imagine. Now, in this day and age, many 80-year-olds are getting their knee replaced so that they can return to a full, normal, active lifestyle, _active. The average 80-year-old from a generation ago was not nearly as active as the average 80-year-old here is in 2021. So those patient-specific jig, exemplified by the Signature, which was it's still available, but it's not widely used, or Biomet product, and that was really quite successful for some period of time. In that first decade of 2000 to 2010, along comes Conformis, which is actually a custom implant that's made specifically for the individual patient. Now, since we've been using it for a decade or so, it has not really gained in tremendous popularity. Even though it's really the only specific custom-made implant that's available in the marketplace, or certainly the most widely used, there are other custom implants for specific situations that are highly unusual. The Conformis has limitations in that it is 3D printed specifically to fit the patient, but it lacks an important asset, and that is modularity. As I said before, sometimes we have to change things on the fly in the operating room, and with the Conformis, it is, a one-trick operative experience. If the conformist either doesn't fit for one reason or another, or for any other reason, an alternative pathway needs to be taken, it's going to necessitate a second procedure. So that has really limited its popularity. Now there are surgeons right here in the neighborhood, including one of my partners, that really like the conformist. So I don't, I don't want to be disrespectful, but it is not caught on. It's not wildly popular in the orthopedic community on a national basis. And I think that's why the lack of modularity, and also you're kind of boxed into one specific system. But there were important evolutionary steps in total knee arthroplasty, and certainly warrant mentioning. So early navigation systems that, in other words, computer generated plans, how you're going to make the cuts, where you're going to make the cuts, didn't involve the use of robotics. It was a fairly rapid transition to computer assisted robotic systems, particularly here in the last 5 years. All of the major vendors have an example. Again, while this is not really truly mature technology, and I think there will be substantial evolutionary development in robotic knee arthroplasty in the next decade or so, they still share many more similarities than they have differences. So they are different in name. They're different in some specific, some patent protected ways, if you will, that differentiate one from the other. But overall, by and large, the similarities far outweigh the differences. Now, of course, the earlier computer assisted navigation systems didn't really have a hand in the surgery, whereas the robotic addition, by definition, the robot, the machine, is involved in actually doing the surgery. Nothing that we can't override, nothing that would change one's instinct as an experienced knee replacement surgeon. But I have to say that, the published thought that it increases our accuracy substantially, as I'll show you in a bit, I think is borne out by my own personal experience over the last several years. The drawback of the current iteration of these navigation systems for robotics is that they are closed source. I think the next and probably most successful iteration to come will be open source, so that one isn't forced to use a specific brand of implants per robotic system as one is now. So for example, you'll see Rosa, which is the Zimmer Biomet robot. That's the one that I happen to use, and I think it's probably the most widely used throughout the country. Not that it's necessarily substantially better than the Navio, the Mako, or the Attune. It's just different enough that you can't interchange if you have a preference for one type of implant. You're forced, I think by design, you're forced into using that specific robot. There is considerable capital outlay on the front end by the hospitals and by the surgery centers in order to make the computer-assisted robotic arthroplasty possible. So once you make a choice as to which implant you're going to use, or which robot you're going to use, and work to the other end, you're kind of tied into that. There are places, there are shops where there may be two different robots, but by and large, I would say that implant choice is more important than do the same thing. As I said before, while Zimmer Biomet, which is certainly the most probably widely available and may have the longest track record, at least for total knee arthroplasty. The Mako has been around and available initially for partial knee replacements, which is a slightly different but very well aligned topic that I have additional specific interest in. Is also, you know, widely regarded as an industry standard. But any of these, whether it's me or one of my colleagues, either here in Washington, D.C. or elsewhere, that's using robotics, honestly, I think they're really pretty close to interchangeable. So I think that's surgeon specific, and I think that it is perhaps even more importantly facility specific because of the initial capital cost of actually getting the robot. These things are, you know, the less expensive ones are on the order of $500,000, and the most expensive bordering on $1 million initial capital outlay before the first case is done. So as you can see, it's a big commitment for the facility, that not so much for the surgeon who's going to use a specific robot because he or she wants to use a specific implant, but that's not the surgeon may have more flexibility in that regard than the facility does. So I wouldn't get too hung up on brands. I think that more or less they are different roads to Rome, but they all get you there. So that's the background. A couple of words now on candidacy. Who is this you know, specifically aimed at? It's pretty broad strokes. I'd say that generally, and probably the take-home point is, it's more or less the same criteria for inclusion in any total knee arthroplasty population. I will say that it may be true in the future, particularly if there's an open source robot where we can sort of mix and match our specific implant needs to match the patient needs. We may start seeing revision surgery done with the various robots, but to date, that is not the case. This is for primary total knee arthroplasty only. That is for the first time on a previously unoperated knee, arthroplasty knee. Many people that come to total knee arthroplasty have had previous knee surgery. So I don't want you to think that previous knee surgery is an exclusion criteria. It's not, but it is for primary arthroplasty only, at least in 2021. I can see that evolving in the not too distant future, probably certainly in the next 5 years or so. So if you're a good candidate for a total knee arthroplasty, then segueing to robotics is a very easy move. Again, pending hospital or surgery center availability and surgeon preference. Surgeon preference is probably not the right word. Surgeon selection based on his or her preference for a specific patient's needs, I think is the more complete and better way of saying it. So now, of course, another sort of interesting thing that's happened in orthopedic surgery in the last few years, and I think Kathy Pulford, who is, I'm thankful for Kathy Pulford in many ways, not the least of which is setting up and walking me through this Zoom conference this evening, but she is an important person in many different ways for the delivery of joint replacement surgery at Sibley Memorial Hospital. And not the least of which is, you know, assessing patients for inclusion criteria for arthroplasty on an inpatient or an outpatient basis. Several years ago, I think we're coming up on 4 years ago for total hip replacement and 3 years ago for total knee replacement, Medicare, the administrative arm of Medicare, which is the Center for Medicare Services, or CMS for short, literally overnight redesignated arthroplasty from an inpatient procedure to an outpatient procedure. And in order to qualify for an inpatient procedure, one has to show need. So, for example, somebody who has very substantial medical problems with diabetes or heart disease, or let's say has an amputation on the opposite side, they will meet need. But the vast majority of people that have a total knee arthroplasty no longer qualify for, quote, inpatient treatment. Now, out of, on the other side, the flip side of this announcement was the designation for outpatient switched as well to include up to 2 midnights in the hospital. So a Monday morning surgery is technically outpatient until 11:59 on Wednesday night. So don't be thrown by the inpatient, outpatient. Technically, it's designated outpatient, but from a patient experience, a surgeon experience, nursing experience, not much has changed other than it's been foreshortened from 3 nights to 2 nights, which is more than sufficient for the overwhelming majority of the patient population. I'd say, and I would defer to Kathy on this one for the exact statistics, but my sort of read on statistical analysis is that the average hospital-based total knee arthroplasty length of stay at this point in time is probably about 1.3, perhaps 1.4 nights. So 60-70% of people will go home the day after, and 30 to 40% probably stay a second night and go home the third morning. As long as you're not there past 2 midnights, it's still technically outpatient. So I just want to clarify that for anybody who might be either concerned or confused about the outpatient designation there. So the inclusion criteria are oftentimes a function of very discrete parameters, including your past medical history, and of course, therefore, on the front end, excuse me, and sometimes on the back end, your internist, your primary care physician, your nurse practitioner, excuse me, is extremely important and helpful in clearance for surgery in the first place. But I think that their value is great and allows us to deliver this in a much more seamless fashion if we clear up any medical problems, issues, dental work, et cetera, on the front end before. Failure of non-operative treatment is, of course, a criteria. Many patients do well for a very long period of time with non-operative measures, including physical therapy, oral anti-inflammatories, especially if there's no other medical contraindications or side effects that preclude us from using those. Injectable treatments, including corticosteroids. The good old cortisone injection is still extremely useful on a daily basis in the practice of knee surgery, but not within 90 days of surgery. We use viscose supplements. You may be familiar with hyaluronic acid derivatives. They come by quite a number of different names, including Synvisc and Hyalgan and Supartz and Euflexa and Gel 1, which is the most modern iteration. They're quite helpful in non-operative treatment, but those cards have all been played by the time we're seeing patients come to the operating room. Again, as I said before, don't be confused by the outpatient versus inpatient designation. Outpatient includes both surgery center as well as hospital-based procedures are both, the vast majority of them are done on an outpatient basis, even if it does involve several overnights of stay. Careful post-operative planning is really critically important. The reason we've been able to move away from more extended inpatient stays and rehab stays is because of really careful post-operative planning to make sure that patients are well prepared, well coached for what's going to happen when they do get home, whether it's truly as a same day or a 1 night or 2 night stay. So that has helped greatly. And of course, that's required a lot of infrastructure that involves people like Kathy Pulford, who help us navigate, us being both the surgeons and the patients, navigate those first couple of days to weeks in the early postoperative phase. So the advantages of robotic surgery are its minimally invasive approach. Minimally invasive does not imply only to robotics, but even to non-navigated systems of intramedullary and extramedullary jigging. It's still a big operation. It shouldn't be thought of as a truly minimally invasive procedure like an arthroscopy. As I said before at the beginning, I do a lot of sports medicine arthroscopic types of procedures as well as arthroplasty. Those truly are minimally invasive that are done with 3-4 millimeter cuts into the joint, where we can accomplish quite a bit. But and arthroplasty, I mean, the implants themselves are just too big to be considered truly minimally invasive. We got to get them in there, and we got to be able to see what we're doing in order to get them in there. But I think that the difference between previous iterations of surgical technique and the minimally invasive approach is big enough but no bigger. So there was a time 20 years ago where the standard was to really widely open the joint, whether it was the hip or the knee or the shoulder for that matter, widely open the joint, really exposing a lot of the skeleton in order to do the arthroplasty. Well, as we became more and more minimally invasive, we realized that, hey, the soft tissue dissection matters a lot, particularly with regard to the speed of rehab and recovery. So the minimally invasive approach, where we make the soft tissue dissection into the joint only as big as necessary to really get the job done, and refining that even further to less and less invasive approaches with regard to muscle sparing and minimal capsular intrusion, has made a big difference, not so much in the outcomes from the arthroplasty, but certainly in the short-term rehab, and I think most importantly in the patient experience, because it's just substantially less painful if it's minimally invasive as opposed to a larger, unnecessarily large surgical exposure to the joint. Anesthesia techniques have also evolved pretty dramatically in the last 5 to 10 years that have allowed for a much different pain control experience than what patients went through as recently as 10 years ago. It can be done in the same day setting, but certainly in the outpatient setting as previously discussed. I alluded to the importance of the infrastructure that's necessary to deliver this. Perhaps one of the most important aspects of that is home physical therapy. Any of you participating in this who've had an arthroplasty back 5 years or greater probably either spent 3 to 5 days in the hospital or spent at least 3 days in the hospital and then went to one of the inpatient rehabilitation facilities in the community. Here at Sibley, it's called the Renaissance. It's still very operation and functional, but very few arthroplasty patients go there any longer because with the switch from inpatient to outpatient designation, the inpatient rehab went the way of the world. It's no longer done for primary knee arthroplasty as it is for revision, as it is for fractures. So far fewer patients are doing that, but that's required a real fleshing out, if you will, of the home physical therapy services. A lot of that has evolved in the last 5 to 10 years. The patients love it because they go home very quickly, if not immediately, to their home environment, where they're much more comfortable, of course, as long as they have good pain control. The physical therapist comes to the house for usually 2 weeks, maybe as many as 3 or 4 weeks in somebody who's moving a bit slower for various reasons. So, but that's been a critical piece of the recovery process. I think that with that, of course, as we've moved into an outpatient setting, we have responded to cost pressures from CMS and from the private insurers we're very cost conscious in pushing it down. And of course, it is a less expensive way of delivering the same service if it can be done on a very short stay or an outpatient basis. I'd like to dwell for a few minutes on the improved accuracy. This has been well studied and well documented in our orthopedic literature. A high volume surgeon is defined by the American Academy of Orthopedic Surgeons as a surgeon that does at least 25 of a specific procedure on an annual basis. Now, honestly, that's a fairly low bar. And most of us that are doing arthroplasty think that, you know, high volume is measured more in the hundreds than in the tens of procedures. We'll call it. So I guess it's a matter of semantics as to, you know, how many you call a high volume surgeon, but a high volume surgeon, by whatever metric one wishes to use, is somebody that's familiar enough, comfortable enough, has done enough of them frequently enough that he or she gets reproducible outcomes, high quality reproducible outcomes. And that is measured and is you know, described by the orthopedic literature as within 5 degrees of ideal in terms of angulation, at least 95% of the time. So that too has become a fairly low bar. Most of us feel that even with the standard extramedullary and intramedullary jigging systems, that an error margin of 1 to 2 degrees is you know, much closer to standard of care and the acceptable norm. 1 to 2 degrees, one way or the other, in terms of angulation is imperceptible from a patient perspective, but nevertheless, we could probably improve on the 95%, right? So we you know, a good surgeon using standard techniques should be able to get that 1 to 2 degrees within, you know, a 95% confidence level. So that you know, now you're talking about a reasonably high bar, but 95, you know, isn't 100, and it sure would be nice if we could push that metric up to, you know, closer to the 99th percentile. And so I think that, and the other issue that I alluded to before about bone being gold and being as bone sparing as possible, really is the true value of the navigation systems and the robotic involvement. I think it allows us to take more precise cuts, taking less bone and pushing that much closer to the 99th percentile. So in that regard, I think it has added value, even though we're only talking margins of value. I think that they're important margins when it comes to outcomes. Of course, we'd like 100% of patients to do you know, extremely well, and the closer that we can get to that number, the better. Time, I think, falls under the same aegis as the minimally invasive discussion. If it's less invasive, the recovery time is faster, and I think that nobody would argue the point that patients are doing better much more quickly today in 2021 from total knee arthroplasty than in years gone by. Nevertheless, you know, it's still a very long, complete recovery process, including outpatient physical therapy and returning to a normal activity level. One doesn't get into the quandary of needing a knee replacement quickly, usually. So there's a substantial deconditioning phase, if you will. If your knee is bad enough that you're considering arthroplasty, then it's probably been bad for, you know, perhaps a year or more, and your ideal activity level has been compromised for that same period of time. So to be able to really get back completely to where you want to be, whether that's with athletics or normal daily activities, or just a generally higher activity level and fitness level for your overall health, cardiovascular health, body mass index, etc. You won't really optimize your outcome for about a year following a knee replacement. But what happens during that year can be vastly different from one end of the spectrum to the other. And I think a better metric that I use and talk about with patients in the office all the time is when are you back to a normal lifestyle? And I think that's a sliding scale, of course, from one patient to another. But most people would tell you that their knee is better than it was the day before surgery when they get to be about a month post-op. Some as soon as maybe 2 weeks, but on average, probably more like 4 weeks. The active phase of rehab and recovery goes on for about 3 months, and then total optimization and recovery, really plan, your knee will, in other words, your knee will get better and better for a full year. So I think that word recovery covers a lot of territory and is, a non-specific term. So I think you have to really pinpoint out what it is you're talking about when you discuss recovery. So as I said before, this is really the robotic outpatient arthroplasty is really only aimed at the primary knee arthroplasty population, which of course is the vast majority of people are getting one knee replacement per side per lifetime. There are going to be patients who either have a complex knee or who have other medical or orthopedic comorbidities, as we talked about before, that do require inpatient total knee arthroplasty. And so for those folks, the robotics is not only less available, but also probably less necessary in that they're not looking for the speed of recovery that somebody who's got one nagging, straightforward arthritic knee is looking for out of an arthroplasty. As I said before, it is closed source. I think, to me, at this point, here we are in 2021, is probably the greatest drawback. In that I am constrained, if I use the ROSA robotic system, to using only Zimmer Biomet products. Now, fortunately, they probably have the largest diversity of implant options of any of the vendors. So that's not necessarily a bad thing, but there are certain circumstances where it wouldn't be prudent to use the robot to force a patient's situation into a specific paradigm that may not be exactly what they need. So it's not for everybody, but it is for most. As I said again, I do expect that to change. I think that the implant manufacturers are feeling this pressure to create an open source product. Mostly because I think they realize that the first one to market with an open source product is probably going to win, a much greater market share of the arthroplasty business from their perspective. It is a bit more expensive to provide this service. There are disposables that we use on a per case basis that add to cost, and this is over and above the initial capital outlay, as I discussed before. So it is a bit more expensive. Thus far, that's been absorbed by the facilities, and CMS doesn't seem to mind that. As things evolve downstream, hopefully not only do they get better, but they get more streamlined and hopefully more efficient, and therefore more cost effective. But presently, as with any new technology, initially, it's bound to be a little bit more expensive, and this is no different from any other example of that you might think of. Speaking of expenses, it is also true that it costs a little bit more OR time, not dramatically so. It adds perhaps 10 minutes. I think once you get past the curve, if you will, after your first surgeries, getting used to the robot and the new tools, you know, you can get it's down to 10 minutes perhaps of additional time to incorporate the robot. I think is, you know, the average total knee replacement for me takes maybe an hour and 15 minutes, an hour to an hour and 30 minutes. So 10 additional minutes doesn't add not any real substantial additional risk. Increased risk for perioperative and postoperative complications is very closely tied to operative time, but it really doesn't take off and become asymptotic until you get past the 2-hour mark. And robot or not, with no robot, it rarely, if ever, takes 2 hours to do a total knee replacement. So, but it's worth mentioning, it does increase OR time, which is a cost consideration from a financial perspective. But the real cost here that I want to assuage anybody's concern about is additional operative risk, which is tied to time, but really doesn't become an issue probably for about 2 hours into a standard total knee replacement. Worth discussing though. So ROSA, the system, the Zimmer Biomet system, is the one that I happen to use. As I said before, I think they are largely interchangeable. That is the robots, but you're then tied to a specific implant system. ROSA is the acronym for Robotic Surgical Assistant, and she's a good assistant at that. She has become an important part of my practice personally, and I think you know, across the country is becoming more and more widely used and accepted. It is versatile within the Zimmer Biomet family of implants, naming the major types of implants: Vanguard, Next Gen, and Persona. All can be done using ROSA. I like Vanguard and Persona for my primary arthroplasties. The Next Gen is also valuable for those who prefer that toolbox. You know, it's not just the implant that brings up something I wanted to make sure I touched on. It's not just the implant that needs to be considered. It's also the toolbox. Just as when you take your car to the dealership, it's not just the parts, it's the tools necessary to do the service that can make or break the outcome. So all the different implant systems have all slightly different toolboxes that go with them. And I think that the ROSA allows for the widest versatility for various implant options within the Zimmer Biomet family of implants. As I've alluded to several times, it is extremely accurate. I mean, we're talking down to the millimeter accurate for minimizing bone resection. Sometimes I can't believe how minimal the bone resection is, and yet by the time I finished the case, it was exactly the right amount of bone. No more was necessary. And that, I think, is very important. One has a tendency to focus on the implants and, you know, especially postoperatively looking at the x-ray, to look at the implants and the bones, which are obviously critically important, but the whole other aspect of total knee arthroplasty that's extremely important for successful, excellent outcomes is soft tissue balancing. And the more the deformity of the knee going into the procedure, the more critical soft tissue balancing becomes. If you have a very arthritic, very painful, swollen knee, but your alignment is normal and you have full range of motion, that's a much more straightforward scenario than if you come into it with a greater amount of deformity, whether that's bowing or knocking, whether that's a flexion contracture where you can't straighten the knee, whether it's hyperextensibility where it goes too far into extension and therefore feels unstable. Getting the soft tissue balancing is critical to an excellent outcome from total knee arthroplasty. It obviously is something that we surgeons talk about all the time, but patients don't necessarily focus on it because you can't see it, you know, on an x-ray. we can talk about it, but it's a little bit harder for you to grasp than is the implant when you're actually looking at a copy of the X-ray or you know, a 3D replica of a total knee arthroplasty. You know, it does, the ROSA robotic system, all the robotic system help us greatly with soft tissue balancing, particularly gap balancing is the term that we use, and making sure that the knee is congruent and stable through a full arc of motion from full extension to full flexion. It has to, not only do the bones have to be resected and resurfaced properly so that it's smooth through that full arc of motion, but also the soft tissue has to be balanced in a similar manner. And Rose has been greatly helpful in soft tissue balancing. You know, that historically that's been a feel, and that's been a function of experience span, that, you know, you have a good feel for soft tissue balancing after, you know, a couple of thousand knee replacements. And that's true. And I would never trust the robot over my own instincts when it comes to the feel of soft tissue balancing. But I have to say that it's an excellent intraoperative, real-time, live second opinion when the gap balancing from ROSA matches my clinical instinct and intuition that it is a well-balanced knee. If it's not, I'm never going to let ROSA override me, but I certainly will take a second look and make sure that I'm right. It can be off for various technical reasons. The robot might have a slightly different reading from what I feel clinically, but for the most part, I'd say it matches with the correlation coefficient high in the 90s, 98, probably 97, 98% of the time. My soft tissue balancing that I can feel and see on the operative field matches what the robot is telling me it is, according to its metrics. So it is efficient. As I said, we get this real-time data feedback while we're doing the surgery, and the immediate feedback, as I said, the best way of thinking of its efficiency is that it is a real-time, instantaneous second opinion to me, the surgeon, on not only the bony cuts, the implant sizes, the soft tissue balancing, but putting those all together for the best possible outcomes. We're saving data as we accrue data from ROSA and from the other robots. A much wider body of knowledge is evolving and developing, and it'll be very interesting to see years down the line what we learn from our post-operative data collection. Pre-operatively, before I make a cut in the knee, I have a pretty good idea from what Rosa is telling me about the mechanical axis of the knee, from the hip to the ankle. What's the plumb line? What passes from the center of the knee? I'm sorry, from the center of the hip through the center of the knee to the center of the ankle is the mechanical axis that we're striving for. I have a very good idea of that, and therefore what I'm going to need to accomplish intraoperatively before I even make the incision with the assistance of the robotic surgical assistant. So intraoperatively, I already talked about, and then the postoperative data analysis is in collection right now. And I think we'll evolve as we go. So outcomes, I want to leave a little bit of time for Q&A here. So I've alluded to a lot of this already. It eliminates outliers. 5% error margin is too great by most people's standards. The computer navigation pushes that to the 99th percentile. Now our goal, of course, is to get it to the 99.99th percentile. So with that, I think we have about 10 minutes for questions. I'll leave my contact information up. If anybody is interested in coming into the office to have a more detailed discussion about their specific issue, please don't hesitate. So with that, I'm going to open up the Q&A box. I see we have one question. Also sent to chat. Very practical question from Mary Jacobs. What exactly does the robot do? So the robot has an extensile arm that goes from the computer. So the difference between computer assisted and robotic assisted is that there's an arm that is connected to the computer, that the computer tells it where to go three-dimensionally in space, that of course it's sterile. I pull it onto the field and it shows me where to put the cutting jigs exactly within the millimeter. And I can also check it. I can double check it and I can double check myself real time, because it knows exactly where it is in space to the millimeter in all axes, in the X and the Y and in the Z axis. I'm getting real-time feedback. So I pull the arm in, I pin the jig, I check it with my clinical sense of what it should be. I check it on the computer screen before I pick the saw up. So I hope that answers your question. It's never meant to override our experience band as surgeons, but it sure is helpful. So any other questions? I don't think so. So that one's answered. Thank you for that question. Very practical, good question. Anybody else? I'll wait for a minute in case somebody's formulating a question as we speak at this point. I will tell you, I think that for some of the common questions that I get about this presently are that I've tried to reinforce a couple of times is, is the robot doing the surgery? No, of course not. I'm doing the surgery. What it's providing me with is real-time insight and information of exactly where to make my cuts. So it's helpful in that regard, but certainly we don't let it tell us what to do. I have another question, I think, here. So, and that too is from Mary Jacobs. Thanks for answering my question. I hope that was a good answer for you, Mary. With that, we'll give it an extra few minutes here. Just to give you a little background about the joint replacement program here at Sibley, has been a very live, evolving entity for many years. Sibley was probably one of the first two, along with the Alexandria group, first two sites in DC to really start delivering outplate orthopedic arthroplasty operations back around 1970 or so, the early 70s. And in that time has gained substantial experience as a reconstructive orthopedic hospital. So it's a great program. We do a very high volume, one of the highest in the Metro DC area volume of arthroplasty operations. It's very streamlined. There's many people involved in the process, including our host, Kathy Pulford, and just a wide array of people and touches that go into delivering this from the moment you walk in the hospital until the moment you're discharged. I'd say there's probably 50, perhaps even as many as 75 different individual touches, from OR nursing staff to technicians and other support staff from both the business side as well as the surgeon side, to our spectacular orthopedic ward nurses who really have been the heart and soul of the orthopedic program for the decades that I've been here. Our nursing is beyond excellent and is nonpareil in my estimation. Worked at a lot of different hospitals over a long period of time, and our orthopedic nurses are by far the best. So I don't see any other questions, and I think we've got 8 participants, but if nobody has any other additional question, I don't see anything here in the Q&A box. I think we'll probably stop there. So it's 6:55. Thank you for your attention. I hope you found it useful and hopefully informative. And again, if I can be of any further assistance, please don't hesitate to let me know.